Hello, I'm Dr. Simon Johnson and I work closely with TSC patients with LAM. And now I would like to share my experiences with you. Lymphangioliomyomatosis, or LAM, a rare lung disease, occurs sporadically or in association with TSC. LAM presents in different ways, either symptomatically or asymptomatically. In the context of symptomatic LAM, people develop breathlessness or they have pneumothorax, a collapsed lung. The mean age of onset is 34 years. However, asymptomatic LAM is generally found earlier in TSC patients because of routine screening. Since the Tuberous Sclerosis Alliance guidelines recommend that women be screened for LAM at or after the age of 18, it's very likely that these patients will be diagnosed much earlier if LAM is present. The vast majority of patients with TSC-associated LAM are women. Although we have identified men with TSC who have LAM, one study showed a prevalence of 13%. Women are also more likely to have lung cysts than men. In my clinical experience, the number of women with symptomatic lung disease far exceeds that seen with men. So there's clearly something about women that drives the LAM phenotype and makes it more severe. Data suggests that estrogen may be an underlying factor in sporadic and TSC-related LAM. Studies have shown that estrogen may enhance LAM cell survival and resistance to cell death. When adult women with TSC are specifically screened for LAM, between 30 and 40% will have evidence of LAM by CT criteria. Experts do not know the exact prevalence or incidence of TSC LAM in the general population. However, you can infer that if TSC is present in approximately 1 in 6,000 live births, and half of those births are female, then 30 to 40% of those females will go on to develop LAM in adulthood. You can calculate an approximation of how many patients may have TSC-related LAM. The majority of patients with TSC-related LAM tend not to have respiratory symptoms. Only 2 to 3% of patients with TSC will have symptomatic disease. However, if screened, 40% of adult females with TSC will have cystic lung disease. The main presentations would be either breathlessness, known as dyspnea, pneumothorax, or chylous pleural effusions, and the first symptoms to appear may be dyspnea or pneumothorax. In my practice, I have seen patients with TSC and severe learning difficulties who sometimes can't vocalize that they have chest pain or they're suddenly more breathless. In some situations, patients may present with behavioral disturbances because they have pain from pneumothorax. So usually, along with breathlessness and exertion or physical activity, patients may experience wheezing and a cough. Sometimes they'll cough up blood. Sometimes they'll cough up sticky sputum. It's actually chylous fluid, a milky substance produced by the body. And some patients will develop chylous fluid around the outside of the lungs, called chylous pleural effusions. These are pretty much the main forms of presentation in the thorax. From what I've observed in my own practice, the main thing that bothers TSC LAM patients is breathlessness, which puts limits on their daily activities. They might think, I'm so much worse at jogging than I used to be, or I get very out of breath and need oxygen when I exercise. There's a huge range of different severities of breathlessness, but that's the main thing that impacts upon patients' lives. For patients with pneumothorax, generally known as collapsed lung, it's very unpleasant, especially for patients who have recurrent pneumothorax. It happens at unexpected times. Sometimes patients may require chest tubes, so there's significant morbidity around pneumothorax. Women with TSC LAM also experience fatigue, and from my own clinical experience, they often feel more tired than their friends of the same age. Another big issue for women with LAM is the risk of pregnancy. Pregnancy can put women with sporadic or TSC LAM at risk for pneumothorax or chylous pleural effusions. So these issues are important for female patients who are considering pregnancy. TSC patients with LAM may be at risk when travelling by air. Air travel may specifically affect patients with hypoxemia or low oxygen in their blood. When the plane is at cruising altitude, the oxygen pressure is lower in the cabin than it is on the ground. If these patients start off with low oxygen levels, because of the way oxygen is carried in their blood, the oxygen can fall quite significantly. So pulmonologists can test patients with hypoxemia to predict whether they will have trouble at high altitudes, and can recommend that patients either do not fly or fly with oxygen. Flying is also an issue for patients with pneumothorax, a collapsed lung, or possible pneumothorax. An asymptomatic patient may become symptomatic as the cabin pressure falls when the plane ascends. TSC-LAM patients should not get on a flight with what they think might be a pneumothorax, and they should make sure that their oxygen levels are adequate before they travel. LAM usually progresses over time, and pulmonologists see an increasing number of cysts in the lung when they repeat CT scanning. They may also see a fall in lung function values, particularly forced expiratory volume at 1 second, or FEV1, and the gas transfer test. This happens at a very variable rate. Some people may progress very slowly, and many people live with asymptomatic disease for many years. But some patients may have a more rapid progression and can develop respiratory failure over a number of years. LAM can even be fatal to some patients with TSC, or can result in the need for lung transplantation.